A patient was diagnosed with bladder outlet obstruction due to prostatomegaly, 60 grams. Mention the investigations necessary for preoperative diagnosis. So they have given you 4. So the patient has a prostatomegaly. Now the question is that what is the question is that what are the investigations that you are required to do in a prostatomegaly? Number one is that you need investigations to see for the confirmation of the diagnosis. Okay. Now, confirmation of the diagnosis will require you to do an ultrasound transabdominal of the KUBP. It is also going to show you the complications that arise due to a prostate, like bladder changes, like kidney changes due to the prostate enlargement. Number 2 is that, and after you have confirmed the diagnosis, to support your diagnosis, you are required to do an urine for culture, which is going to rule out an urinary tract infection, and you are required to do a PSA. Particularly, remember that you are required to do a PSA as a baseline, particularly if the prostate has felt hard or nodular on the DRE. Now, there are concerns about doing a PSA in a normal population, but this one is a gentleman who was presented with a bladder outlet obstruction. Number 3, it is always important to do an urodynamic assessment, and the better word is uroflowmetry. Now, both are different terms, both are not the same. Uroflowmetry is only about measuring something called as the Qmax. That means the maximum flow rate. This is the normal Qmax. What is the flow rate? And the flow rate is usually more than 20 ml per second. Okay. The minimum volume that you require is around 250 ml. If it is less than 150 ml or 100 ml, this result doesn't have any importance. So the Qmax is estimated, and depending upon the Qmax, if the Qmax is less than 10, the patient goes for an early surgery. If the Qmax is somewhere between 10 to 20, you can start medications and then maybe followed by surgery. So this completes the first basic things. Number 4, for anesthesia assessment, I can write like complications also. It is always important to do a sugar, urea, creatinine. What I would like to do is that I like to give a star mark in this one, given the point that patient can have a chronic renal failure. So this is the anesthesia story about this in this part. So these are the investigations that you are required to do this. You can be more elaborate on the urodynamics, but for 4 marks, I think, or for 3 marks, I think this is enough. What are the medical treatment options and surgical treatment options? The medical treatment options for a benign hypertrophy prostate are usually the first line of medications always will be alpha blockers. Particularly remember that the patients who are more with a irritative symptom like frequency, urgency, nocturia, they are given a start of alpha blockers like tamsulosin, silodecine, etc. The second line drug, now this is not exactly first line, second line, prostate which is more fleshy and soft but bulky disease will get 5-hydroxytestosterone, so or 5-alpha reductase inhibitors. Now, the best example is finasteride, dutasteride, etc. So, these are the second drugs. It is usually seen that on a combo therapy, the results are much better. Alpha blockers usually will produce an quick onset of relief. 5-alpha reductase inhibitors will produce a long-lasting effect. This is a medical. You are also required to know about the common side effect of these drugs. Talk about the surgery. What are the options? I will divide them into an emergency surgery, where the usual emergency is retention urine, and I will like to do a suprapubic, I would like to do a per urethral catheterization. If failed, you'll end up with a suprapubic cystostomy. If it is elective, then depends upon there are multiple factors, but usually it depends upon the weight of not the patient, the weight of the prostate. Anything greater than 120 grams or anything with a complication like a stone in the bladder, etc., or a diverticulum should call in for an open prostatectomy, which nowadays is very rarely done. But if it is at all done, you go by the retropubic or the Mellin's prostatectomy. If the weight is somewhat between 120 to 80, people have now done something called HOLAP or HOLEP. Okay, so this is something called as holmium laser HOLEP, holmium laser prostatectomy, or something called laser TURP. Something between 40 to 80, you do the classic TURP. Okay, something between 50 to 80, or with an obstruction, there are other options like PUIP, an incision in the neck. There are many other procedures that have not stood the test of time. The gold standard is always an classic TURP. So please remember that these are the surgical options that we usually talk. We can go more elaborate on that, but remember that the examiner is giving you this one only 3 marks. So with this, ladies and gentlemen, I think we'll be ending.